Hello, I'm Dr. Ilene Ruhoy. I am a neurologist and environmental toxicologist. And on the next episode of Dr. Eleanor Stein's podcast, we will talk all about chronic and complex illness, specifically the different diagnoses of Septad and my book, Invisible No More, and the different ideas that I go over in more detail. But it was a great conversation, and I hope you join us.
Welcome to the Dr. Eleanor Stein podcast. In this show, you will hear expert medical professionals, researchers, and people with lived experience share science-based, low to no cost strategies to help people with complex chronic diseases. Listen in for another dose of education, empowerment, and hope.
Hi, everybody. I'm Dr. Ellie Stein, and welcome to the Dr. Eleanor Stein podcast. Today, I am honored to be talking with Dr. Ilene Ruhoy. She is a neurologist who is pushing both diagnostic and therapeutic boundaries for our community. I've been following Dr. Ruhoy's work for a few years, and she is the real deal. In her popular podcast, Unraveled, she and colleague Dr. David Kaufman go deep into the weeds of complex chronic diseases, and they share their expertise on how to manage and treat the myriad of complicated symptoms that we all experience. Unraveled is a real service to the community. There's no dumbing down. They tackle the complexity of these conditions. Dr. Ruhoy is a triple threat. She received her MD from the University of Pittsburgh and completed her residency in neurology at the University of Washington. Then she went on to get a PhD in environmental toxicology, and she completed the Integrative Medicine Fellowship with Dr. Andrew Weil. Currently, she has a private practice at the Center for Healing Neurology in Seattle, Washington, and has served as the medical director for the Chiari-Ehlers-Danlos Syndrome Center at Mount Sinai Hospital in New York. She serves as an advisor or director of several organizations focusing on connective tissue disorders, Chiari malformation, and syringomelia. I hope I'm saying that correctly. What I didn't know until recently, as I started looking, kind of researching everything that she's done, is that she's actually published a lot of peer-reviewed papers. And many of them are very recent. I'm just going to give one example that kind of blew me away. It's called Comorbidities and Neurosurgical Interventions in a Cohort with Connective Tissue Disorders. It was published in January 2025. And in that paper, it's a retrospective study of 717 patients with connective tissue disorders, exploring all of the comorbidities, like how many of them have MCAS and POTS, Chiari malformation, and how many of them went for surgery. So I would say Dr. Ruhoy has more experience than most dealing with these connective tissue disorders and all the things that stem from them. The reason I reached out to her for this interview is she recently published an amazing book called Invisible No More. As a geek in the field, I found it a gripping read, kind of like reading a novel. In it, she shares her own personal story, her formulation of complex chronic diseases, which she refers to as post-exposure illnesses, and it's packed with practical symptom management strategies. So welcome to the podcast.
Thank you.
I'm wondering if you'd be willing to share a little bit about your personal story, because it's very impactful. And to me, it helped me understand, why you're doing what you're doing right now.
Sure. I mean, I write a lot about it in the book, of course, but briefly, about 11 years ago or so, I wasn't feeling well. I was working and I knew just something didn't feel well and things just kept getting worse. I mean, I did all that I know to do to try to improve the fairly vague symptoms that I was having that just seemed to progress and were impacting my daily life. And so I started to see doctors, a lot of colleagues of mine, some that I didn't know all that well, just because I was really looking for an objective perspective on what could be going on. My exam was normal, my labs were normal. And so really I was told that it was anxiety, it was stress, it was perimenopause, it was all kinds of things that they love to tell women. And I guess I wanted to believe that were true, right? So I just sort of went on about my business, but everything just continued to get worse until it really came to a head. And so I just cried to one of she wasn't even my doctor. She was a new doctor to me, but an acquaintance of mine, and to order me an MRI because no one would. And so she ordered me an MRI, and that's sort of where my odyssey began because I came out of the MRI machine and the tech told me to go right to the ER, but didn't know why. It was just the radiologist had sort of called down and said, send her to the ER. And so, of course, I went right to the ER, and I was diagnosed with a 7 centimeter tumor that was basically pushing one side of my brain to the other side. There was a lot of swelling. And, in retrospect, a couple of things. I look back and I think, one, they saw me as female first. And I wasn't a neurologist. I was a woman, basically.
Mm.
And then two, had someone believed me earlier on, then perhaps, and I'll never know the truth to this, of course, but perhaps the tumor would not have grown as large as it had. Because
Right.
ultimately now I'm sort of struggling with what happened is there have been 3 recurrences. So I've had 3 rounds of radiation to my brain. I
Wow.
was immediately admitted after I was diagnosed for a very prolonged surgery to try to resect the tumor. They had to remove part of my sagittal sinus. And they had to scrape it off my brain. So in the end, what was technically not a tumor of the brain tissue, was a tumor of the meninges, actually invaded the brain. So, and invaded the rest of my meninges. So I still now struggle with some small tumors that continue to persist, that I get MRIs for every few months. That we're following their growths, and so anyway, so I still have the persistence of the
Yeah.
remnants of this very large tumor. And I've gone, like I said, several rounds of radiation, and there's no treatment. So it's just, so I wish someone had earlier on believed me and had ordered an MRI for me, but nobody did. And so anyway,
Yeah.
so the
Yeah.
reason why I talk a lot about that in the book was because the experience, of course, is not only fairly traumatic, but it made me realize like how horrible it feels not to be believed. I was
Right.
trying to convince them, like, no, something is wrong. Like I was always, I never had, I don't have a history of anxiety. I don't have a history of not managing stress, but I knew something was not right, but no one would believe me. So that was a horrible feeling. And I thought, I can't allow other patients to feel this way, right? So, and I was already a practicing neurologist, and not that I didn't believe patients, but I like doubled down on it, as I say. Like I
Hmm.
thought, I'm going to really, like I'm going to look for the reasons for their symptoms. I'm going to not only believe them, but I'm going to try to validate them the best that I can. And so, because before that, I would say that I was probably practicing sort of in that box that a lot of medicine really exists in these days, which is that you do a certain set of labs, a certain set of imaging, and if things look normal, you really don't know what's going on and you can't localize it. And I'm not sure of the treatments, and you can try some medications. But I just thought, no, I'm going to not stop until I figure out why this patient is suffering with that symptom. And so that's what started my whole journey actually into this space where I am now. And, frankly, it's these patients that are the reason why I'm here now. I'm grateful for the patients that I've had over that was this was 10 years ago, my
Yeah.
diagnosis. So I'm just grateful for the patients that I have because I learn from each and every one of them. And so I'm constantly learning every day, every week, every month. And the more I find, the more I learn, and the more I talk to other doctors who are doing similar work. I'm not the only one, but the more I talk to and work with doctors who are doing similar work, like you mentioned, Dr. Kaufman, who I do the podcast with,
Hmm.
the more I learn. And I feel like we know so little in medicine, and we don't acknowledge it enough. Is what I think. Like, and not that any doctor would argue that. We all know there's a lot more to learn. That's what research is about. But I feel like we have to sort of on the surface recognize our limitations, which is that we don't really know what we don't know, right? So
Right.
so I learn new things from patients, and so I'm just grateful for them, and they're the entire reasons why I'm here today and why I'm still here. And also, and I feel like I'm rambling to your one question.
No, no, this is great. I think people will really relate to this because they're like, oh, she's one of us. Yeah.
Is that I forgot my thought now, but
So sorry.
no, that's okay. I just feel like I'm rambling to your one question. I'm going to just take over the entire podcast with the answer to one
Well,
question.
don't worry, I'll move us along.
Yeah, I feel like I've just acquired a lot of tools in my arsenal
Hmm.
really go in different routes that are sort of well beyond neurology and certainly well
Right.
beyond what I was trained in residency. And, and I'm always willing to be wrong. I always, maintain my curiosity as to why. And I love to talk to other, my colleagues, even in neurology, who are receptive to it, to just sort of have a conversation as to what else could be happening. And so and it's what I was going to say was that, and it's the entire reason why I think I haven't burned out. I mean, a lot of doctors are burning out and leaving
Mm.
the field, and that's not really a reflection on them. It's a reflection on our system here in the States. Actually, it's very broken. It really doesn't support it doesn't work for patients. It doesn't work for doctors. So doctors are burning out very easily and are leaving the field, which is such a shame because patients need doctors. But I believe that my persistent curiosity and the investigation work that I do and the detective work that I do for patients has what's kept me going. It's because like every day is different. And what am I going
Yeah.
to learn today? What am I going to do today? What am I going to think about today? How am I going to synthesize a new thought for that particular patient today? Plus, I get to know my patients on a deeper level. So I feel like I have all these additional relationships in my world that bring me, joy, that serve me and nourish me as I hope I do for them. And that's another thing
It's
we can talk about is that whole patient-doctor relationship. It should be a therapeutic relationship,
yes.
hierarchical, right? It's not a dictatorship, right? So, it's really a mutual relationship. And I see it as any other relationship in our world, right? So
Hmm.
they're my friends and, I'm their doctor, of course, and I'm there to help them, but I also get to know them on a much more of a social level as well. And there's a mutual trust, I guess, is my point, right? So, and
Hmm.
I think that's what serves us. It serves them and it serves me. And even if I'm not like actively getting them better yet, it still serves them to know that I believe them, that I'm working
Hmm.
with them, that I'm trying to find answers. So yeah, so there's a lot to it. And I've really come to enjoy medicine more than I ever have.
Yeah, I'm just kind of resonating with everything you're saying. So I'm a retired psychiatrist. And in the Canadian healthcare system, of course, we also have many challenges. But one of the benefits of being a psychiatrist is you're actually allowed to spend time with patients. There's no limit, like you don't have to fit
Right.
everything into 10 minutes or 15 minutes.
Yeah,
And so,
that's
just like you said, I really got to know people over often many years,
Mhm.
right? They maybe go off and come back, and you really get to see them progress and meet their family members and sometimes even their pets.
I love the pets.
Yeah, yeah. And I had a cat for many years, and some of the patient, because I worked out of my house, they would ask, can Tasha come in? And she
So
was,
your cat was like a support cat.
yeah, she was a support cat. I of course had to keep her out because some people are allergic, but
Yeah.
some people would ask for her, and it was just like you say, especially in psychiatry, and I think in medicine in general, we're taught that you have to have these rigid boundaries,
Mhm.
and I've
Yeah, that's true.
haven't bought into that, because like you
I don't
say,
know how to do that.
yeah, they're real people, and you form real relationships.
Yes. Yes, and you can't, I don't think you should halt that process. If it's a natural building
Hmm.
relationship, there's something very, I don't know, very astute and magical in that relationship that I think, again, really serves the therapeutic nature of that relationship, right? So, I mean, there's a reason why they come to see you, right? Because they need
Hmm.
your help, they need your expertise. And so that's where it starts. But as you get to know them, when you connect on a deeper level, I believe that that's when you start to sort of see them for who they are. And in many respects, sometimes I start to see their symptoms for what they are. And I get a different perspective on where to look, how to approach it, how to even treat it. So I
Hmm.
find it, so it's multidimensional, right? And I think that this two-dimension treatment plan, or I should say, the two-dimension relationship between doctor and patient really does not serve either one of them well. And I think if we just sort of embrace this idea that there's a deeper relationship that should be had there, I truly think that a lot of doctors would be less dissatisfied with their occupation, with their profession. Um, so yeah, and so that's what
That's
I
really,
and
yeah,
I've
that's
done
an
that like
interesting hypothesis.
yeah,
Yeah.
I seen it be true for me, so I don't want to pretend it'd be true for everyone,
Hmm.
but it certainly has been true for me. And as you know, as a psychiatrist, the best antidepressant is helping someone else.
Yeah,
You know,
absolutely.
that really does serve me. And so I often say, I love the work that I do because I'm helping others and it brings me joy. And it distracts me from my own trauma and my own medical history and all of that. So anyway, so I feel
Yeah.
strongly about that aspect of what I do.
Yeah, thanks for really sharing that. And I wonder, so how did you get into this field? So you're a neurologist. It doesn't necessarily follow that you'd end up working with people with long COVID and ME/CFS and
Right. Well, so I went into private practice 10 years ago,
hmm
just so I can give time for patients. I didn't have
hmm
time in a more standard institutional setting. And so I went into private practice, gave them the time, started to learn about them, and started to sort of see a lot of common denominators in their
mm
stories and their backgrounds and their history. And that was very curious to me. And I started to try to explore that more. I looked, online, I read a lot of articles, and then some of the pieces that kept coming up were some of these diagnoses that we see in the chronic illness world, like mast cell activation and,
hmm
POTS and, other autonomic diagnoses. And they were all coming to see me because they had neurologic symptoms, whether it was neuropathy or headaches or visual disturbances or dizziness, those kinds of things, cognitive concerns. Uh,
hmm
and I started to put a lot of pieces together. And then I found other doctors who were doing similar work, not necessarily neurologists, but other doctors. And so I joined some of there are like these groups that I'm part of where these doctors talk about cases and different approaches that they've used, things that have helped, things that have not helped. Anyway, so it was like one piece after another that I just kept building. And before I knew it, I realized that the PhD that I had gotten, which by the way, I'd gotten before I
Oh, okay.
became, so um, was very apropos because we're talking about exposure illness, right? So
Yeah.
things we're exposed to in our world, which again, most commonly are infection, right? Which is what long COVID is, obviously, in its name. And ME/CFS is known to be another post-viral
hmm
syndrome. But there are other exposures, and my PhD proved to me that our environment is just dirty. I mean, there are contaminants, intoxicants, and all kinds of things that we're just exposed to on a daily basis from the air, the water we drink, the soil where our food is grown, and so on. And so when you put that all together, you recognize that it does have an impact on our health and our physiologic mechanisms, especially those mechanisms that are meant to keep us well and safe. And you start to sort of see what these patients are suffering from when you take a deep history in terms of their exposure history. Where did they grow up? What have they been exposed to? Also, what infections have they had throughout life? What medications have they used over the course of their years? Whether it was multiple rounds of antibiotics because of
hmm
infections or other, medications that have known toxicities. And we're all different in the sense of the way our bodies metabolize and handle certain exposures. And that's based on our genetics, sometimes epigenetics. And so you start to see it for the individual as opposed to like an overall problem. And when you sort of take it down into that microcosm of a level to that individual patient and sort of look into like, well, why you? Why did this happen to you?
hmm
What is your exposure history? What's your family history? And then you would look into a little bit of the genetics and do some analysis, and you can start to find answers. And the most important point about that is that those answers will lead you to, there's a lot of treatments to try. And a lot of times we go through trial and error, and that's unfortunate. And we all do it, including myself. It's frustrating for the patient. It's frustrating for me. But so the more data that you can accumulate with regard to that individual patient, the more of, I refer to it as sort of an informed decision I can make on a treatment recommendation that has at least a higher yield chance of being beneficial for that patient, right?
Right.
So I can't guarantee it, of course, because there are no guarantees in anything that we do in medicine. But any medication that we even use, I mean, if you look up the clinical trials, it'll say 70% of the patients responded, the other 30% didn't. So it's the same. It's not that, but with more data points, you can try to get that patient into that 70% that did respond, if you have a better understanding of who they are and why they are, kind of thing.
Yeah, so I want maybe that's you're kind of focusing on two separate aspects. One is the big picture, and I
Mhm.
wanted to ask you if you could say more about this pentad or septad,
Yeah.
the common conditions that you see in, say, the complex chronic disease community. And then I love that you then kind of segued into the deep dive on an individual patient. Like, just because the average person has these 7 things, they're going to be reflected differently in
Absolutely.
every single person.
That's an excellent point. So if anyone listens to my podcast with Dr. Kaufman, we talk about the Septad diagnoses, or even when we refer to it as peptad or decatad
I
these
know
days.
it's getting bigger.
I know it just continues to increase. We refer to it as a roadmap. And
Okay.
it really is a roadmap. And we like it as a roadmap, especially for doctors who are not yet as familiar as we are with this patient population, because it gives other doctors an idea of where to start, of like how to, what to treat first.
Mm-hmm.
And sometimes based on those diagnoses, you can ask the patient, what is your most prominent symptom that's really impacting your quality of life on a daily basis? And if you can take that symptom that they report back and put it into one of those diagnoses, and that's where you start. That's what you treat
Mm-hmm.
first. And very often it's the autonomic symptom or it's the mast cell symptom. So the most
Right.
common places to start are either the POTS or the MCAS. Now, POTS is sort of, a surface description of an autonomic problem, but there's treatment for it. So it is a good place to start. I fully admit that. So you either start with POTS or MCAS most commonly. Oftentimes, the reason behind the POTS or the MCAS is an infection or other exposure. And so if you identify what that is, you can treat that exposure, whether it's with antibiotics for, a bacterial infection or antivirals for a viral infection, or some of the new monoclonal antibodies that are out. Or even if it's another exposure, things like, of course, mold is very common, and people treat it right. And it's
Yeah.
also important, I will say that I'm not literate in treatment of tick-borne disease. I mean, I've learned a lot from Dr. Kaufman. I fully admit that, but I still defer to doctors like him who are well more versed in the different antibiotic options, certainly. And then I'm definitely not literate in mold treatment. So, I try to focus in on the neurological aspects of
Right.
their symptoms because that's who I am and what I do best. And I don't think it's fair to patients for me to try to treat something that I'm not completely comfortable with. I mean, I sort of know where to start if I have to, but when they don't respond, I don't know where to go from there. So I usually defer to doctors who are a lot more literate in those kinds of exposures. But the point being is that if it's an exposure-driven symptom that even though it might sit in the house of MCAS or in the house of POTS, then you still want to treat it as MCAS or POTS, but you do have to get to the root of why that happened and treat that as well. Unless it's been so chronic that sometimes you just got to treat what has happened as a consequence of that exposure first and foremost. Otherwise, recovery can be impaired or not full. So
Yeah. So I'm hearing you say you're trying to find the root causes and you're trying to ascertain the direction. Like, is this causing this? In which case, you got to treat point A, or is
yeah.
B causing A, in which case you want to focus on point B first.
Exactly.
Yeah.
I will say that sometimes the symptom, which again can be from the mast cell reactivity or the autonomic disorder, can be so debilitating that if the first
Right.
step would be to treat that, because then the patient will get a little bit of relief. And then, sometimes the symptom itself can impact their motivation to try different things, right? They're just suffering so much and they've been suffering so long
Yeah.
that they get very frustrated very easily and they'll try something for a couple of days and sort of say it's not helping, it's not working. But, you have to really be able to be willing to try it for a couple more days, or maybe at a higher dose. Like that's why I say the relationship is so important, because you have to trust me, like, so that, and I always say to patients, we're going to start with this medication. I start low, I go slow. I need to hear how you're doing. We'll tweak it as we go. But that requires a level of a trust, a mutual trust, right, between patient and doctor. And so that's where that relationship is so critical to what I was saying
Right.
earlier. But anyways,
And the constant feedback. So I'm hearing you say
constant
it's
feedback.
an iterative process. You're not just saying
Right.
come back in a month.
Right. No, exactly. And definitely, I mean, have an appointment in a month just so
Yeah.
we can document what's happened and what our next steps are. But I definitely want to know in a few days, like, did this medication at this low dose do anything for you? If not, let's increase it.
Right.
The first goal is to make sure you tolerate it, right? And if you're tolerating it but not getting a great benefit, then we're going to increase it. So but the goal, of course, is to manage that most prominent symptom so that they don't get as easily frustrated, and so that their motivation to continue on trying and continue on to trust me will increase. And that really helps the relationship going forward. And I have so many patients now, that I've known for years that remember early on that I was just like, trust me.
Just
I don't
try
have to
it.
say those words because it sounds a little like, I got you. And it's true. I feel like I got you. Like
Yeah.
we're good. We're good. Don't worry. I know what's going on. I've heard the symptom before. I very commonly say to patients, I don't know if this is reassuring or not, but you're not alone, right? I've had lots of people say the same thing to me, that of their symptoms and how they're suffering. And I always say, you're not alone. And I've seen this before. So
Yeah.
this is what happens. This is why we think it happens. And these are the various things that could potentially help. And it's never just one. I always say there's no magic bullet. Otherwise, everyone would be cured. Right. So there's a lot of things to try. And I will say, the other thing that I'll add is long COVID and the research in long COVID gave us a ton of insight into what is going on in these chronic illnesses, and also a ton of ideas, because a lot of money into that research. So that was good, because out of that came, again, a whole new perspective on different physiologic mechanisms that are at play, which gave me a whole new perspective on different kinds of treatments I can try. And
Such as what are some of those new perspectives that?
Yeah, so well, we know that there obviously long COVID is persistence of spike more than persistence of virus itself. A lot of the research is basically confirming that. And so
Okay.
when we see what spike does, we think, okay, well, how do we minimize spike binding for sure, or even just eradicate the body of spike, which is really hard to do. But, there are some monoclonal antibodies on the market that are meant to bind to the spike protein binding domain and help to remove it from the body. And so we can reduce at least the spike burden. We talk about the burden of the body of a particular antigenic component or antigenic fragment, which, antigen, as you know, is what the antibody connects with and forms that immune complex. And so these different viruses and bacterium have, very unique antigens. And sometimes those antigens look like pieces of our body. And so our immune system gets confused. And so it creates an antibody against that piece of our body that looks like that antigen, which is called molecular mimicry. And so that's where sort of autoreactivity starts to play a role, and then the risk of developing an autoimmune disease. So a lot of this, and I only point that out because a lot of this we see as being immune mediated.
Right.
So in that regard, I've been using a lot more immunotherapies, to treat patients, and with some decent success. So it just sort of, gives me more idea. I know the mechanism of action of all the drugs that I prescribe. So based on what I hear back with what, whether there was a benefit or not, and what the benefit was, what symptoms seem to improve, or what side effect might there have been, it gives me an idea in terms of that particular patient's individual physiology. Like, okay, this mechanism of action was useful for that patient. So let's capitalize on that. Let's, improve that momentum, and let's keep going on that trajectory. And that's how I see it. And sometimes if there's a side effect, I think, okay, well, we don't want to particularly touch that receptor because this drug works on that receptor. So let's avoid anything that will affect that receptor. So, I tweak my plans based on, again, the drug that I've prescribed and the patient's response to it. And long COVID taught me to do that because I had all these new ideas from the research, just from what they've shown with the spike, even referring to like T cell exhaustion, mitochondrial dysfunction, which is definitely in my wheelhouse. I've done a lot of mitochondrial medicine in my career. It just gives me sort of these ideas of like, oh, how best can we correct that? So that's what long COVID research has given us in the chronic disease world.
Can you just kind of review what are the pentad or the septad, just for people that haven't heard it before? Like, what are the areas that you find kind of common in people with these conditions?
So there's no real consensus. That's the funny part.
Yeah.
As a neurologist, a lot of my diagnoses are actually neurological, but they all contain the POTS, the MCAS, often the small fiber neuropathy, which is actually part of the autonomic disorder, umbrella, because the small fibers are part of the autonomic nervous system. Some GI dysfunction, usually some level of dysmotility, whether it's gastroparesis or constipation, which of course increases the risk of developing things like SIBO. So there's a GI component, there's an infectious / exposure component, as I already mentioned. So a lot of patients are worked up for different, viral illnesses or exposure to viruses. We know that COVID, for example, reactivates certain viruses, also can reactivate some of the bacterium of the tick-borne disease world, whether there's like a mold exposure, as I said, but there are other environmental contaminants that we look for sometimes. There are, specialized labs that, you can look for like heavy metals and those kinds of things. And then there's the connective tissue component to all of this,
right?
Sort of where I've really focused a lot of my work, because I would get in, patients would regularly, these are young people too, like 20-year-olds, if not younger, but young adults for the most part make up a major part of my patient population. And they all have headaches, and they all have neck pain, and they all have back pain. And so I would get imaging, as a neurologist should do, right? Even though my neurologist early on did. But a neurologist should get imaging. So I would order MRIs of the brains and the spines, and I would see these 20-year-olds with spines that are just falling apart. And, it didn't, wow. And I was like, and I know that, you're sort of taught, well, were they athletes? Did they have a lot, were they football players? Did they have, fall off a horse several times if they were equestrians? Like those kinds of things certainly can lead to spinal issues. Obviously, if there's been a lot of physical trauma early in their teenage years and throughout, Right. So their spines just looked bad. I mean, there was, multi-level degeneration. There were bulges. There was, where the vertebral bodies slide, forward or backwards, called listhesis. And you would see straightening of the cervical spine regularly, because it's supposed to have a natural curve. It would lose that curve, and it was straight, and that's not supposed to be. And that would often cause neck pain, and sometimes there's some associated muscular spasm. And then you would just sort of see where the brainstem or the posterior fossa as well would sit a little bit too low, and couldn't really understand that. And then I would commonly see what's referred to as partially empty sella, or an empty sella, which is of the sella turcica, which is the bony pocket where the pituitary sits. It would be filled with fluid. So that often is associated with like pressure disorders. When I saw it the first, second, third, fourth, fifth time, like, it was like, okay, well, I'm not sure what to make of it, but I would regularly see it, and I would correlate their symptoms with it. And then I started to think, why is this 22-year-old spine like an 80-year-old? Like, I don't understand it. And so then I started to read about hypermobility, and, there's been more research on hypermobility in the past year than there has been in the past 10 years, in terms of hypermobility being a risk factor for certain things like Chiari's, things like even headaches, all kinds of different things. And so I just got into that, did deep dives into that space, and recognized, wow, connective tissue, which you barely spoke about in neurology, and
not even mentioned in medical school, not at all. Yeah,
I know, it's crazy, is way more than what we think it is. It's much more than mechanical and structural of our joints. And by the way, even on that level, the spine is a series of joints. So it's very much affected by even, when you talk about dislocations and subluxations of the hips or the shoulders and the ribs and so on. I mean, it happens in the spine. And so, but it's also everywhere. The vessel walls are connective tissue, the meninges are connective tissue, the fascial planes are connective tissue, some of the hollow organs are lined by connective tissue, and so, and more, right? So even like bone is specialized connective tissue. So I started to realize, well, if something is wrong with the connective tissue that's holding a joint together, then why not other parts of connective tissue? So I started to see this as a neurological problem. And sure enough, it is. And in fact, I'm chair of the neurology committee of the EDS Society. And so we're in the process, the committee which is full of neurologists and neurosurgeons. We're in the process of writing up a manuscript on neuro-EDS, because it really is a neurological disease is how we see it. Because there are so many neurological symptoms of hypermobility. And there's a lot of anatomical diagnoses that result in those neurological symptoms, of course. And that's part, going back to your question, that's part of my Septad diagnosis, right?
Yeah.
cervical instability? Do you have tethered cord? Do you have an internal jugular vein compression because of either an elongated styloid process that's sitting on your jugular vein or a C1 tubercle? And if there's any kind of compression, then there's congestion back into the brain, which causes a whole host of neurologic symptoms, right? So I see these anatomical diagnoses as part of that septad. And so that's, as a neurologist, that's the role that I play in working up these patients. And I often find stuff, right? I would say that it's a rare time that I don't find one problem, at least on their imaging, that is related to their connective tissue that also correlates to their symptoms. So
And
that's,
would you say, I mean, in my experience, and again, I've been working in this field for the last 25 years, so a little bit earlier. I mean, if you even mentioned it, you would be totally dismissed by the
yeah.
local neurologist, and the neurosurgeons wouldn't even take the referral.
Yeah. I mean, it still does happen occasionally. It happens a whole lot less. When I first started doing this work, I would get a lot of calls from neurologists and even some neurosurgeons and would say to me, why is everyone being diagnosed with EDS right now? And I'm like, well, I think that we're just getting a better understanding of connective tissue. And I will fully admit that I'm not so sure this should be called EDS, which obviously is a well-known genetic hereditary connective tissue disorder. And we have yet to find the gene of the hypermobile type. But I also think, a couple of things. One, maybe it's polygenic, but two, perhaps there's a certain genetic component that sort of sets you up, and then it's an exposure that does the damage that causes that variant to be, expressed. And we know that in medicine, we have a lot of those disorders that are called the two-hit hypothesis, right? So you have the genetics that sort of make you vulnerable to it, and then especially in pediatric neurology, there's a couple of epilepsy syndromes that you're born with the genetic variant of it, but it's not until the kid gets their first viral exposure that all of a sudden they have that disease.
Oh, interesting.
Yeah, and there's a couple of other diseases that have similar two-hit kind of onsets.
On that, one of the things I learned from your podcast, which I hadn't thought of before, is that this hypermobility can also be acquired. So, and in your book, you talk about that as well, that the ongoing inflammation, and maybe you want to say more about inflammation, actually causes the degradation on an ongoing basis of the connective tissue. And when I read that or, heard you talk about it, I went, oh, that makes so much sense. It's not just a one and done genetic event.
No, I completely right. And that's the acquired component, right? You don't even necessarily need the genetics, though I think that there's probably some role of some genetic variant. But yes, I see a lot of patients that it's an acquired form of hypermobility. The mast cells alone have 1,200 mediators and 300 receptors on their membranes, right? So, and some of their mediators are enzymes that love to break down collagen, which is the major component, of course, of the connective tissue, and it's the major protein of our body. But in addition, though, not only the collagen forms the primary structure of the connective tissue, but then there's the extracellular matrix that also has collagen fibers that are non-contributory to the primary architecture of connective tissue but have a lot of also cellular components to it. The extracellular matrix is actually very complex in its structure and requires a lot of gene inputs, to make the enzymes to create that for the cells to be created to come together to be part of that extracellular matrix. And in fact, some connective tissue disorders are because of genetic variants that result in abnormal activity of some of the enzymes or some of the substrates or cofactors that are necessary for those enzymes to form those components of the extracellular matrix. Yeah, exactly. So it's very complex. And so, so when you have any kind of exposure or immune assault, those mast cells, which again are the first responders, right? They're there to fight. They don't care who the enemy is. They just fight whoever comes their way. They're releasing all these mediators that are creating this systemic chronic inflammation that also includes neuroinflammation that just with these enzymes that are being released breaks down the connective tissue. And so patients who were not necessarily hypermobile to begin with, and I don't think that they become all of a sudden like this big flexible like Gumby character, but I do think that for whatever reason, the assault targets a particular part of their body, the anatomy. I mean, I've had patients who are not hypermobile at all, but have clear CCI on their imaging.
Wow.
And that CC joint is held together by multiple ligaments because it is so critical, and it houses the lower end of the brainstem as well as some other, very important neuroanatomy. and if you get their history, they have history of, multiple concussions, TBIs,
Right.
so there's been a lot of whiplash. And so I think that the focal point of inflammation for them is in the upper cervical spine. And so,
Okay.
so it doesn't have to be systemic in terms of degradation of connective tissue. It can be
Okay.
very focal. And that's an important point because I think a lot of doctors are sort of sidetracked by the fact like, oh, they did the Beighton scale in the
Right.
office and, they
They
got one
didn't
or
pass.
two. Right, exactly. And so that doesn't mean that they don't have a connective tissue problem, but it's just more focal.
Okay.
And that's an important point. But it could be acquired again based on what their history is, which is why history is so important.
Yeah. I'm
I think,
just wondering if we can really shift gears here a little bit. So, up until now, you've talked about, I'm going to add the word overwhelming complexity of these conditions.
yeah,
But in your book, what I loved about it, one of the many things, was that you also talk about self-management. Like, yes, you've got all this complex biomedical stuff going on, at multiple levels. And it's also true that what we do ourselves on a day-to-day basis, the decisions we make
yeah,
about sleep and exercise and diet and managing stress, those kind of things can have a really significant role to play in healing. I'm just wondering if you could say more about that, because in this community, as you know, a lot of people are really hanging out for the fancy biomedical treatments and
yeah.
maybe at the risk of offending someone, maybe don't pay quite as much attention as they could to some of these things that we actually can do ourselves.
Yeah, I mean, I'm glad you brought that up. I really struggled with that second part of the book, to be honest with you,
Okay.
because I see so many chronically ill patients that I knew that I probably I wasn't sure how they would like be how receptive they would be to this
Hmm.
idea that a lot of what we do in general for ourselves can play a role, right? Because I know
Yeah.
that my patients obviously they can't exercise. They end up with post-exertional malaise or just more fatigue and sometimes flare of symptoms. And the autonomic nervous system, when we exercise, it very much relies on our autonomic nervous system. So it can sometimes flare symptoms very easily to even mild movement, even going for
Hmm.
walks. So I fully aware of that, fully aware of that. So I have really had to struggle with like how to word things and, with
Yeah.
with understanding that this would not apply to all of the patients with chronic and complex illness. But I still think it's important in the sense of like the resiliency of our bodies like and I don't
Okay.
know if I was successful in making that point in the book, and at least in the second half of the book. I think the resiliency of our bodies is what keeps us alive and what keeps us fighting back the exposures, or at least the consequence of those exposures. And the more that we can improve the resiliency of our body, the better off we'll be to any extent. And I'm not saying that it would be a cure, because it certainly won't be.
Right.
But it could help any intervention that's done. It could help your body tolerate that intervention. It could optimize the response to that intervention. So it's really about the resiliency of the body. I mean, I have such great respect for human physiology and what it can and cannot do. And that's what I was thinking when I was writing that part of the book. Like the more that we can, improve the resiliency and respect that physiology, the better off our homeostatic mechanisms can play a role, which we need, right? We need that
Hmm.
to come back online. And so we have to support them so that when they are able to come back online, it's with more efficacy. And I don't know if that makes any sense, but
Yeah, no, I think about it in a very similar way. I think about Dr. Navio's cell danger response and the
right,
healing cycle. And like, how can we give the body the right messages that healing is okay and safe to
exactly,
do, right?
exactly.
And I think all of that, like, you know, what I'm really focused on right now in my retirement, quote unquote, are those kind of self-management things. Because out there in the big world, not everyone has access to someone like you or some of the tests or treatments that you talk about in your book, but everyone has access to the small decisions they make every day.
Yes, exactly. And I really do believe that. And I very regularly guide patients on, even with sleep, and we talk a lot about, nighttime and how we sleep. But I think I point out in the book, it's really also important to focus on what you do during the waking hours, right? So
Hmm.
bodies are circadian. It's a 24-hour cycle, give or take. I know we've been forced on 24 hours, but it's not technically an absolute 24 hours, but regardless, it's a good
Hmm.
close estimate. So what we do when during the wake hours of that cycle are actually just as important as the dark hours, as the sleep hours. And a good rhythm during those waking hours can help set up for a better sleep at night. Right. So I think that's important. And, one of the things that I'd like to point out is that the reason why babies thrive is because we put them on schedules, right? Of when they eat and when they sleep, and that's how they thrive. They're rhythmic beings, as we all are. We don't lose that as we get older. It still
Right.
applies. It's just that modern life, gets in the way. We have to go to school. And, there's been lots of even research talking about having teenagers start school at 7 a.m. is
Oh,
insane. Like that's not where their rhythm is at that age.
right.
And so but we force it, right? So modern society has really disrupted a lot of our natural rhythms. So I try to help guide patients into how to simulate a more natural rhythm if possible. It's not always possible, of course, and I totally understand that, and I never insist on it. I meet the patient where they
Hmm.
are, and we work with it. We do baby steps of trying to
Yeah.
simulate a more natural rhythm because that will improve the resiliency of the body.
And what about some of the other self-management, maybe diet, because you go into that in some
Yeah.
depth, and you even mentioned some supplements as well in your book.
Right. I think I make a point of saying that supplements are not going to make a huge difference. And
Yes.
but having said, people are always asking me what my favorite supplements are. And so I
Can
give
you,
my favorite.
sorry to cut you off, can you just say more about that?
Yeah.
That's such an important message, and I don't want to gloss over it, that
Yeah, of course.
they're not the end all and be all.
They're not even close. I mean,
Okay.
as anyone who knows and you pointed out that I did the Integrative Medicine Fellowship as I had done with Dr. Andrew
Hmm.
Weil at the University of Arizona. And so it's not that I'm not about natural care or holistic care. In fact, for in earlier parts of my career, I was referred to as an integrative neurologist, which I fully embraced because I, do believe that if we can do something more naturally, we should. And that's, those are the things that we sort of talked about already and even pointed out in my book, like sleep and nutrition and those
Hmm.
kinds of things. But supplements, first of all, that all of them have excipients, and if you've got mast cell activation, I mean, that's a problem, right? Those mast cells don't like anything that's foreign, and those excipients, and which are preservatives and fillers that all these supplements have to have, really can be dangerous for some patients, and they're not going to tolerate it. The other thing is that they're not FDA regulated, which I'm not a big fan of the FDA, don't get me wrong, but it just means that we don't really know what's in there when you're buying
Right.
them. And I have patients come in that are spending hundreds of dollars on supplements every month. They bring their bags of supplements. They don't even know why they're taking half of them, which also applies to medications. So that's not necessarily a dig at supplements in general, um, but they're not studied enough to know, like, should you be taking these 10 at the same time? And I don't think that anything that you can just buy on the internet or on the shelves of a store hold the power or the potency to really fix a lot of these issues, right? So I feel like, and I always talk about, like, to get you better, we need to get you on a track of where you're improving. And I do think supplements play a role as supportive at some point in that trajectory. But until we get on that trajectory, until we get on that healing path,
Yeah.
we're going to need to do things that are a little bit more aggressive, which usually means pharmacologics, right? They're formulated to work fast and to be efficient and effective because this sounds very, I guess, like almost like harsh, but they somewhat hijack the physiology.
Yeah. They
That's what they're meant to
override.
do. They totally
Yeah.
do. Right, exactly. And so, but there's a benefit to that, which is that we can get you better faster. And as I said earlier, if you tell me that this symptom improved with this medication, I know exactly what's helpful to your physiology because I know the mechanism of action of that particular drug. So I
Hmm.
do think that it starts with medications for sure. And then once there's healing, then we can support it with supplements. But again, I just have never seen supplements play a critical role in recovery of any of these illnesses
Yeah,
ever.
I have to agree with you, even though people love them.
Yeah, they love
Um,
it, and I get it. They
yeah.
want to feel avoid, big pharma gets a really bad rap. And again, I'm not a fan of them. I'm not paid by them, but, but they really do make some very useful therapies for patients who are suffering with these chronic illnesses. And I think that's an important point. And if we can start there and we agree that if, again, the trust issue, right?
Yeah.
Agree that at some point we can wean off this medication and try to supplement with targeted supplementation. And by the way, this doesn't refer to if you identify, some deficiency in a vitamin, obviously replete it. I mean, I'm not against that, of course. I'm saying in terms of as a treatment plan for chronic and complex illness, the supplements are just not the place to go.
Yeah, that's such an important message because, like you say, people have limited resources and we have to be very, I don't know, smart, I guess, about how to spend them.
I agree, completely agree. Yeah,
Yeah,
you're right. We have to be discerning in terms of what we choose to spend the money on and what we choose for the treatment for our bodies. And again, supplements are not benign. They have all those excipients,
right.
not only that, but the capsule ones, they're in these little plastic, I mean, microplastics, right? A big deal.
Oh my gosh, I
I mean,
didn't
we're
even think of
swallowing
that.
all these plastic capsules. I don't know if you've ever gone to the drugstore, but you can actually buy a bag of 1,000 of those.
Yeah, yeah. I've done it.
This is what we're swallowing. So, again, they're not completely benign. And so when patients ask me about supplements, I just say, let's hold off on the supplements for now. Let's try this plan and sort of see where it takes us. So
So, if someone, just to kind of wrap up a little bit, if someone is listening to this and maybe they're quite new to this, like they're still trying to figure out what's going on with them, and they're like, "Oh my gosh, she just mentioned like so many things."
yeah, it's a lot.
Where would you say someone should start?
Well, like I said, so that's what the Septad is really useful for.
Okay.
So what prominent symptom does the patient have and where does it fit in those
Yeah.
diagnoses? And so, you need to have a doctor who's receptive to these ideas and to start with sort of, and there's first line treatment for all of those diagnoses. And it's actually fairly easy. So I would hope that they have a doctor who's interested in helping
Yeah.
them, curious to sort of see what helps them and what doesn't help them, and have them just sort of focus in on that particular diagnosis and start treatment plans. Again, there's a lot of articles these days that are written on treatment for MCAS, treatment for POTS. This is
Hmm.
not hard to find. And, back in when we were young doctors, we didn't have the internet.
Yeah.
These
Oh my
days, like the
gosh.
stuff that I can find in 20 seconds just by typing in a question, like there's no reason why even young doctors can't learn how to treat patients with these diagnoses. So
Okay. That's really reassuring, right? That the information's out there. It's not out of reach anymore.
not at all,
And
not at all.
an average open-minded, say, family doctor or internist
Yeah.
should be able to go, oh, okay, I understand enough to help you.
Right, exactly.
Yeah.
It is not even outside the box that much anymore. I mean, like I said, there are consensus guidelines on how to treat some of these things, not all of them.
Right.
Some of these diagnoses are still somewhat controversial in certain circles.
Right.
A lot of them, well, especially the treatment of them, like the medications themselves have been around for a really long time. They're well understood and and prescribed often. So it's fairly easy to at least get started with treatment for any primary care doctor for sure.
And then if someone wants to work with you or some other person who's more expert in the field, I don't know if you're taking patients. I don't know if you're taking patients from outside the US or how that works.
So I'm only seeing patients through a practice based out of New York now.
Oh,
So
okay.
I've recently sort of my practice was acquired by Atria, who's in New York, and so I'm
Okay.
one of the neurology team of Atria, which they're phenomenal there and have really high caliber doctors of all specialties, frankly. And
Hmm.
so that they have a website and people can learn more there.
Okay. And so that means you're no longer working in Seattle?
No, I am in Seattle, so my practice is still in Seattle. I just travel to New York a couple times a year, but
Wow.
I see patients through Atria here in Seattle.
Okay.
Yeah.
Thank you so much. Are there any, I guess, in the show notes, of course, we're going to put links to your podcast
Mhm.
and a mention of your book. Is there anything else you want people to know? I guess places to find good information.
Um, there's a couple of really useful sites that I could
Hmm.
share. Um, but I think the podcast and the book is really, I think that's
Okay.
great if you can just have those links. Yeah.
Thank you so much. This was just like full of useful information. I really appreciate your time.
No, I appreciate the invite. It was really fun to talk to you, and I appreciate your interest, frankly, and your support in chronic and complex illness.
Thank you.
Thanks for joining me on the Dr. Eleanor Stein podcast. I hope you are taking away new strategies and ideas to improve your health and a renewed sense of hope. Join me, Dr. Eleanor Stein, for our next episode. Can't wait? Check out my website for a wealth of free resources.